It's now time check. It's now 9:30 and we'll start so that we can also end early. So good day, everyone. Welcome to the 5th session of the Introductory Pediatric Palliative Care course. I am Doc Alden, a clinical fellow in training for the Pediatric Palliative Care Fellowship under Two Worlds and Hyderabad Center for Palliative Care. And I'll be your facilitator for today. And today's topic is about symptomatic management or symptom management in pediatric palliative care other than pain. We have discussed last week about pain management, and now we're going to move over to the different symptoms that pediatric palliative care services handle. So without further much ado, I will introduce our speaker for today. She is a pediatric palliative care specialist, and she is also a faculty of the Clinical Fellowship in Pediatric Palliative Care under the collaboration of Two Worlds, Cancer Collaboration, and Hyderabad Center for Palliative Care. So I give the virtual floor now to Dr. Spandana Rayala. Dr. Spandana.
Thank you, Alden. Thank you. Am I audible?
Yes, you are.
Thank you. Let me go ahead and share the screen. Hello, everyone. My name is Dr. Spandana, as she said, and I work with the team that is organizing this ECHO series. And right now I have relocated to Kuwait, but I'm basically from India. And it is very, very interesting because I have attended the last week's session, and as I have said in the chat, you are a very interactive group. So if you have questions coming up, please feel free to post them on the chat, or we could always take questions after the slides, just to not interrupt the flow. I would request everyone who is not speaking to mute themselves. Thank you. So today we are going to talk about a very important topic in palliative care, and you will see why I call it a very important topic. One of the major symptoms that we give a lot of importance to, and which has a lot of effect on the patients, is pain. And that is why we did a whole session on it. Having said that, there are other symptoms that do take a lot of an effect on the children. Sorry. Are the slides changing, Alden? Can you see my second slide?
Oh, it's not moving, Dr. Spandana. It's in
on the first slide.
Yes. It's not yet on a slideshow. Yep.
Yeah, I changed it, but it tends to do that every time. So can you see that now?
Yes, much clearer.
Yeah. So the objectives today are to talk about some GI symptoms, some respiratory symptoms, and we can talk about bleeding and also transfusion support when it comes to end-of-life situations in children, feeding around end of life, and also how to say someone is close to death. I'm sorry. I think people have unmuted themselves and I could hear the echo. I request all of you who are not speaking to kindly mute yourself. And there are many more symptoms that we wouldn't be talking about today. So here is a slide showing the common end-of-life symptoms. And as you can see, there are many, many symptoms. And one of the major one is pain, and that is why we have discussed that already. But then there is also breathlessness, fatigue, nausea and vomiting, seizures, which sometimes can be at the end of life, but also even before that. And then constipation, secretions, one common complaint that they do have, urinary retention, hunger and thirst, and also even the whole concept of existential suffering. Coming to how do we assess and manage these symptoms? Just like any other issue in medicine, whenever we see someone having a symptom, we take a good history. When did it start? How is it happening? How frequently is it happening? And questions like that. That comes under evaluation. And also we assess the patient, do a proper physical examination. Irrespective of where the patient is, whether the patient is in curative phase or in palliative care phase or in end of life phase, it doesn't matter. We always have to take a good history and an examination, and our management is not complete without that. And then we look at treatment of underlying causes. Is it possible to treat the cause? And we always question ourselves that. So if the cause is infection, is it possible to treat that infection? Or if the cause is pleural effusion, can we drain the pleural effusion? So always think about, can we treat the underlying cause? And then think about other options to manage the symptom, because as you know, these are palliative care patients, sometimes at the end of life, always giving them intensive treatments might not be helpful. And then the pharmacological therapy. And more than anything, you have to remember that what the symptom means to the family, the meaning of the symptom is how they express it. So sometimes the patient is in pain, the patient is vomiting, but the family will only tell you he's not eating anything from 2 days. He's not eating from 2 days. So the family is concerned only about the not eating part. They think once the child eats, everything else is going to be all right. So what do they think the symptom is? Where do they think the symptom comes from? And how important they think the symptom is affects how much they're reporting that symptom. So always remember that could be one aspect that could affect the way we record the symptoms, the way the symptoms are reported to us. Just a second. Yeah. And then when we talk about integrative and rehabilitative therapies, what we mean here is not always every symptom responds very well just to the medicine that we give. Sometimes there are some small things, we will talk some specific things as we go forward, which help in helping the patients feel so much more better and make them so much more comfortable. For example, let us deal with nausea and vomiting. So just like any other symptom, it is important to assess how the child is feeling. So there are some standardized scales, just like we showed you in the previous class on how to assess pain, the various scales such as revised pain scale, the FLAC-R scale. Here we have a BARF scale, which is the Baxter Animated Retching Faces scale. You could just show the child how the child is feeling when it comes to the nausea and vomiting. This is not feelings, but this is how they feel when it comes to their nausea. And then they are going to look at the scale and they're going to tell you this is how much nausea I'm feeling. And it is always good to note how much the child is feeling, because tomorrow when you or your nurse assesses this patient again, it is always good to know if the medicine helped them or not. Did it make a difference or not? And here is non-pharmacological interventions, which I was talking about, the integrative and the rehabilitative ones. For example, in nausea and vomiting, provide small meals and let the child choose the meal. If they're curative, probably we want to look at the calories, we want to look at the nutrition, how well they're receiving it. But if you think the child doesn't have a lot of time, then probably we have to look whether the child is enjoying the food or not. So we have had children in our hospice. We have had children in our hospice who wanted Coca-Cola for breakfast, who wanted ice cream for lunch. And we did not stop them from having that, because the goal of care was not to build their nutrition, but to let them enjoy the little time they had. So based on the goal of care, make sure you are providing required meals to them. And also, whenever you see a child with nausea and vomiting, make sure you examine their oral cavity. Sometimes even simple fungal infections could be causing nausea and vomiting for these children. And also remember that when children are very sick, mothers do not insist on brushing their teeth, brushing them. And that could be a reason why they do not feel like eating. And also remember to avoid discomforting smells, especially in a hospital setting. Also, there are some children who wouldn't want to smell the food when it is being cooked. That could be a problem for them. So just be mindful of these things so that you ask them when you're assessing your patient. And also aromatherapy. This is something I've seen as a kid also when we are traveling, when we expect motion sickness, we carry a lemon in our pocket and we just smell the lemon when we are having that motion sickness. So just remember that using something as simple as lemon, ginger, mint can help the child deal with the nausea. And acupressure. So this is something that can be easily done when you close your two fingers, the middle finger and the ring finger. You usually get a small ridge here. Just put your three fingers, and below the index finger is the point where when you place pressure, apply pressure here in the gap between the two tendons, acts to decrease nausea and vomiting. It does work. I have specially tried the one they do for headache. For headache, it's the point between the index finger and the thumb finger, and giving steady pulses. It shouldn't pain them. It shouldn't be that strong that it causes pain. So doing this makes a lot of difference. This is for headache. And the one you see in the picture where you can identify the gap between the two tendons and you apply pressure there. And that is where you get relief from nausea and vomiting. That is something very simple and that could be done even at home. And then we do have to remember when we are talking about medications, what, as I said, a lot of times consider palliative care as tender loving care, and that looking at the prescription, it seems like there are the same old drugs that we are using every time for the same, for similar symptoms. But we do have to remember that even though the drugs might be limited, there is always a certain logical thinking that goes behind about why we are using that particular drug for this child. And it is not the same drug we are using every time, but we are also thinking about what are the receptors that are getting triggered in this child? What could be the reason why this child is having nausea and vomiting? And if you look here on this flow chart, you can see there are several centers. For example, if you go on to the left side bottom, you could see increased intracranial pressure. And this we see with some hydrocephalus children waiting for VP shunt, and also we see with new onset or even metastatic brain tumors. And this causes headache and vomiting. And you know that. And the treatment for this increased intracranial pressure is definitely dexamethasone. And as you all know, using 2 to 3 days of mannitol. So it is not as such an antiemetic dexamethasone, but it helps with nausea and vomiting here. So we would call it an antiemetic in this context, right? And then the vestibular system. We were just mentioning about motion sickness, but also a cause could be opioids. And here we can use scopolamine dimenhydrinate. And then there are certain, I'm sure in oncology, you must have heard the anticipatory vomitings because of the anxiety the patient has before receiving chemotherapy, that itself causes vomiting. So they're waiting for chemotherapy, they have not received chemotherapy, and the patient starts vomiting. And for those children using anti-anxiety medications, anxiolytics such as benzodiazepines works really, really well. And coming to chemoreceptor trigger zone on the right side, you can see that. That could be because of, again, as it points out, many, many reasons, one of which is chemotherapy. And you all know that for chemotherapy, the cetrons, the 5-HT3 antagonists work really well. And for opioids, the drug of choice, as we say, is haloperidol or metoclopramide. And the ones below, the GI tract vagal, There is distension and stasis here. This is something we see quite common with neurologically affected children, neuroatypical children. And because their GI tract is affected and mothers are quite enthusiastic in feeding them, sometimes they do not, and the GI stasis, they vomit because the food that they're given is not digested, and because the peristalsis is affected, it is just in the GI tract. So thank you. Just a second. Thank you. And in these children, using metoclopramide, domperidone, which are prokinetic agents, works really well. So remember that it is not a one-shot treatment for everything, but every time we are looking at patients and thinking, what could be the reason for this, and then give it. So as I already said, opioid-induced nausea, haloperidol, and metoclopramide work really well. There are some opioid antagonists that we can think of, but a lot of times we do not have access to them. For example, naloxone, buprenorphine. And opioid rotation is something we have tried, but it tends to be usually very costly because morphine is one of the cheapest opioid available out there, and rotating to fentanyl is helpful, but remember the cost of it might be difficult. But most of the times the nausea and vomiting because of morphine comes down within 2 to 3 days. It is something the patient gets used to over a period of time. And then the chemotherapy induced nausea and vomiting. The 5-HT3 receptor antagonist ondansetron metoclopramide. And we have already spoken about glucocorticoids, which can help especially in brain tumors, benzodiazepines when you suspect there is an anxiety component, and dopamine antagonists. Haloperidol is used in delirium, which we wouldn't be speaking in this session, but it is also very, very helpful by its action on dopaminergic 2 receptors. And then we have a quite costly drug, aprepitant, NK1 receptor antagonist, that is also very useful. And the slides would be shared with you and you will have access to the medications. The other symptom, very important symptom, especially if you are part of oncology centers, is mucositis. And a lot of times as palliative care people, we end up seeing them even though they're not palliative, but also curative. I have had a child, a 5-year-old child with such a severe oral mucositis that he abandoned treatment. So there is a high risk of treatment abandonment, especially when parents do not know about treatments properly, if the mucositis is not well treated. And that is why you will see that we have many, many options to treat mucositis. One way is, the first thing when someone says they have a burning sensation in the mouth or they're not eating well, definitely we have to examine their mouth and we look for, as the picture suggests, any white patches. Is there an ulcer? Is there any redness? And one way to control pain is giving them small ice cubes, the ice chips, so that they feel better. The other thing some kids like is, while receiving their chemotherapy, they tend to eat ice cream or suck on ice lollies, so that decreases the blood circulation to their mouth during the chemotherapy. I do not know how effective that is, but it seems to work well. And then also remember that what the parents are giving when the child has oral mucositis, giving any kind of salty, spicy food at this time, they wouldn't be very happy. And then for mild to moderate mucositis, remember we have some mouthwashes, analgesic mouthwashes. We can just give salt gargles, and in our ward sometimes when we cannot even make the salt water, we give them the 0.9% normal saline for washing. Bicarbonate can be little tricky because sometimes it can cause a little burning sensation in the mouth. Just be mindful of that. And you could use 2% lidocaine syrups for gargling, and if required, antibiotics and even antihistamines might be considered. And then there are different ways people try to use, I'm sorry, these slides are moving without me moving them. Yeah, so as I said, something that you could do is use a half teaspoon of salt in a glass of water, and that could be used to gargle, because we do not want to ask them to buy normal saline at home and gargle. So this is something they can just do at home. Get clean water, add half teaspoon of salt, and if you think it is infected, or if you think there is foul smell from the mouth, adding uh, soda might help, baking soda. And but again, in pediatrics, I'm little concerned, but there are conditions where sodium bicarbonate might help, the baking soda. So just be a little mindful of that. And there is something that they call magic mouthwash. It's a local formulation. As you know, we get some antacids, magnesium or aluminum hydroxide. Adding that with diphenhydramine and the lidocaine 2% viscous, we can mix that, add in water, swish and spit. Again, a lot of people use Benadryl. They mix and match stuff. So this is not a standardized one. And then do remember, we have had children with such severe mucositis that we have to give injectable opioids. We had given injectable morphine to children with severe oral mucositis. And here are some resources for oral mucositis. And dyspnea, one of the most difficult symptoms. If you think about it, think about the time you were in a changing room and trying to change your clothes, and your head got stuck in a shirt, right? And you couldn't take it out. Knowing that, it is still removable, you still had that I am going to die fear. So imagine if the child has to go through that all day long. And in the beginning, I have said, based on how they feel, they report the symptom. And not all the time they'll tell you that I have breathlessness. They tell, I have chest tightness. I feel something is sitting on my chest. And they use words like that. So be mindful of the words they use to express their dyspnea. And remember, it is not an objective observation. So if someone tells I'm feeling breathless and you look at their chest, you cannot tell, oh, you are breathing normal, your breathing is 14 times a minute, so you don't have breathlessness. It doesn't work that way. Breathlessness is how I feel. It doesn't have to do anything with my respiratory rate. That is tachypnea. This is dyspnea. So anything that is difficult is dyspnea. And then the pediatric dyspneic scale. So again, you show this to the child and you ask them, how difficult is your breathing? So as you can see, very sorry about the slides, they keep moving without me changing. So as you can see, they have the faces, but there are also the lungs where you can see that the rope is constricting it. So you ask them how they feel about that. And then again, each patient answers from a scale of 1 to 7, how much it is. And then do remember, for dyspnea, non-pharmacological measures are everything. Especially whenever we can't breathe, we get anxious, right? So the first thing, I think, more than anything, is reassurance. I am here. I'm with you. Is the first thing. The second thing is having some ventilation, opening the window, having a fan blowing on their face, and then comfortable position. A lot of times we tend to put our patients, lie down, lie down. No, for breathlessness, let them sit in the position they want. They want to stand, let them stand. They want to sit, let them sit. They want to lean forward, let them lean forward. If possible, if you have access to air conditioner, decreasing the temperature might make a difference for the child. And remember, in a lot of conditions, oxygen is not going to help with dyspnea. And also address anxiety by providing reassurance. And there are some breathing techniques. So this is something you place one hand on your chest, one hand on your abdomen, and you ask the child to breathe through the nose and breathe out through the mouth. And when they do that, the thing that should move is the tummy. Their abdomen is the one that goes up and down. Right? And distraction like play, music therapy, because this is a continuous symptom that they're having, and having family around them, right? And we also use morphine. Morphine is considered gold standard. And this decreases their feeling of dyspnea, decreases their respiratory drive, decreases their hyper-responsiveness, and decreases oxygen consumption. A lot of times, even in non-cancer children, we have started them on morphine, and we have weaned their oxygen off so that they can go home. The other thing that you can think about is benzodiazepines such as lorazepam and midazolam. I will just stop my slides here because I think we are crossing the time. Uh, uh, do we stop here, Alden, or do I just do transfusions? Because I would want to cover the case presentation. I think more discussion is generated when we do case presentation.
Yeah, you still have 5 minutes.
Okay, thank you. Then I'll just cover transfusions. Thank you. Regarding transfusions, a lot of times, again, as I said, the first thing I think as a palliative care trained doctor or people who are looking at palliative care, we have to decide what is the goal of care for this child. Am I thinking this child is going to be completely cured, or do I think this child, think someone is,
Okay, I'm looking who is.
yeah, I know. It's it. Yeah, I got. Yeah, I got it. I think I got it. Yeah. So the transfusions around end of life. So if you decide this child is curative and has a chance of benefiting from transfusions, yes, we go for it even in palliative care. But when we realize that the child is at end of life, then we think, what is the benefit of giving transfusion and what are the harms of giving transfusion? As you all know, transfusions come with risk, but while curative, the benefit is very much and the harm is less. So that is why we give transfusions. But as time goes by, sometimes the benefit goes down and the risk increases. So that is a huge discussion to have with parents. And again, that is out of purview of this, but yeah, definitely this is something we can think about. In adults, especially when you see head and neck cancers or even liver diseases, bleeding could be a cause of death, but in pediatrics, it's quite less. But if you think there is a chance that the child is having vomitings, hematemesis, and that is how the child is going to worsen, having some dark towels ready is important. Having some midazolam or lorazepam, benzodiazepines, opioids ready is helpful. Tranexamic acid, you could have it on the side, but they rarely help in these conditions. Maybe if it's a local wound that is bleeding, it might help, but systemic, it is not actually very helpful. And I'll just skip the secretions, but there is one thing I wanted to talk about is how do we identify a child is end of life? So when a child is sleeping more and they're not awake like before, or when they look very pale and the breathing pattern has changed. And I've had children who used to be on the phone all day long, used to watch movies, used to play video games and all that on the phone. But then as end of life approaches, they just don't look at the phone. They're just lying down. They don't want to talk. You could see that they're worsening. So they lose that enthusiasm for life. And then the breathing pattern changes. Right now, I have a child with brainstem tumor who has Chine-Stokes breathing. As you can see, the breathing goes slowly, it increases, then it decreases. And then for small periods, the child is not breathing, but again, the child breathes. And in a way, I show this to the mother and I tell her, look at the breathing. The child is stopping breathing. So it shows me that the child is not doing well. So identifying these signs, the ones I just showed you, are good to start a discussion.
Yes, thank you, Dr. Spandana. Is that the last slide?
Yes, it is. Yeah. Sorry, there was disturbance, so I just stopped.
All right, so the floor is out now open. In the interest of time, we could accommodate one or two questions starting from the chat box. Dr. Spandana, Dr. What's this? Dr. Kausar Ali is asking, oxygen is not helpful in dyspnea. Please explain. Not always. Oxygen is not always helpful in dyspnea. Is there Dr. Spandana, are you there? Are there
Yeah.
any situations that can we provide an example of a situation that oxygen is not helpful in dyspnea?
Yeah. I know that Dr. Catherine is here. I would like to hear, I mean, she has taken the time and joined, so I would like to ask her to answer, but
Catherine is here?
yeah, Catherine is here.
Hello. Thank you, Dr. Spender. You would have a beautiful answer for this, I know, but I think the point about oxygen is that you know, when you're thinking about patients that don't have a curable condition, right, and you're at the end stage of an illness, we can't, with oxygen, you can't bridge that. So we use oxygen when, let's say, when there's something reversible. But when someone's towards end of life and they're hypoxic, the oxygen is not going to reverse the condition. So actually what you're focusing on is not the numbers and the oxygen level, but what you're focusing on is the experience, the symptoms, right? So what we often see, certainly I'm thinking of in MSF settings, is that children stay in hospital at end of life on oxygen and they die in the hospital. Whereas actually, if we'd given them morphine, which helps with their experience of breathlessness, they would have been able to go back to their home with their family. And we can't get oxygen in the home in the many of the places that we work, right? So sometimes oxygen can help with a symptom, but it's not, let's say, when you have the reversible condition, actually probably treating the symptom itself is better so that the child is not spending the rest of their life attached to the oxygen tube. I don't know if you want to add anything to that, Dr. Spandana.
Yeah, I love some excellent points that she has brought, especially about the child being stuck in the hospital with an irreversible condition and the oxygen is not helping. For example, look at cyanotic congenital heart disease, inoperable. Right? So no matter how much oxygen you're giving, the moment it enters the heart, it is going to get mixed. And their saturation, it's going to increase by maybe 2-3%, but not more than that in my experience. But just because you say that oxygen is important in the hospital, that child is never going to see his house ever because knowing that it is inoperable. I'm not saying no one should ever receive oxygen. What I was trying to say is based on the condition, we have to decide, right? So definitely what she has, Catherine has said is excellent in the sense that we have had children who were on oxygen in the hospital. We brought them to hospice, or even in the hospital, we started them on morphine, made them a little more comfortable, slowly weaned off oxygen, and then they were ready to go. So I request people who are not speaking to just mute. But if you want to speak, definitely we would be more than happy to take your questions. I just see one question right here, morphine dosage for dyspnea frequency. And so we use half the dose of pain. So normally we give 0.2 to 0.3 per kilo per dose in pain. So we give around 0.1 milligram per kilo. So if the child is 10 kilos, we give 1 milligram. And we usually start at 8 hourly instead of 4th hourly like in pain. In pain, we give 4th hourly, whereas if the child does not have pain and it's only dyspnea, we give it 8 hourly. And sometimes if the child is not comfortable, as we said, there is no ceiling dose for morphine. So we increase the dose and we increase the frequency. From 8th hourly, we make it 6th hourly, then make 4th hourly. So yeah, we keep changing the dose.
Okay. So I think there were two questions entertained. Dr. Ali, the question that you asked had already been answered a while ago. Don't worry, the recording will be made available in a short while after this session so that you can go over the answers. And then in the interest of time, allow me to have a brief introduction to our case presenter. She is also a fellow in pediatric palliative care. She's a fellow in training, and she's also a pediatrician working in Hyderabad. Without further much ado, I give now the floor to Dr. Archana Iyengar.
Thank you, Alden. A warm good morning and good evening to all of you. Rizwana, can you please share the slides?
Can you see it, Achanandi?
Yeah, it's a first slide. Thank you. Can we start with the case? It's the next slide, actually. Yeah, thank you, Rizwana. So here we have going to discuss regarding a child over a 6-week period. We have a 2.5-year-old child diagnosed with acute myeloid leukemia. He relapsed 2 months after chemotherapy was started. The child is receiving palliative chemotherapy for symptoms and to prolong his life, but this treatment, we all know for sure that it would not be curative. So you have completed an extra training in palliative care and are providing palliative care at your hospital. You have known the family since the day of diagnosis, and you are planning to provide palliative care to the child. So this child has completed the 6-cycle palliative chemotherapy. His counts are low. He's unable to eat because of severe pain and mild nausea. The pain might be due to severe mucositis, as Spandana has already discussed. Rizwana, can I please have the previous slide? So for the pain, he is receiving a continuous morphine infusion subcutaneously. Next slide, please. So in this child, what medications we would be using to treat his nausea? What non-pharmacological treatments would be helpful? So anybody in the audience would like to share their thoughts? It's already been discussed by Dr. Spandana. If anybody would like to share their thoughts.
Any from the floor? A non-pharmacological. If you're shy, you can put it in the chat box. Lemon ice cream from Miss Regina. Thank you, Miss Regina.
Hello, everyone.
Yes, Miss Elizabeth.
Yeah, for non-pharmacological treatment, I would use ice packs, or I would not ice pack, but rather lemon or ginger, and acupressure would also be helpful. Thank you.
Thank you, Miss Elizabeth. Back to you, Dr. Archana.
Yeah. Thank you, Alden. Next slide, please. Yes, as can you please mute? Yeah, thank you. Yeah, as already Dr. Spandana mentioned that it's better to provide small meals chosen by the child. Each child has their own favorite food. And as Spandana said that when the goal of care is maybe in the end of life, we should just give whatever the child wants. But if the goal of care is for nutrition's sake, it's better we give small feeds and make them calorie dense, so that at a point of time, the child can take a small feed, but the calorie will be more by adding ghee, sugar, oil, or groundnut powder. We can make the feed calorie dense. So provision of favorite drinks, hypnosis and breathing techniques already that have been mentioned. Good oral care, as Spandana mentioned, and avoiding discomforting smells, aromatherapy, and acupressure. Next slide, please. So pharmacological nausea medications, we should consider the mechanism first before starting the medications, because it can be gastrointestinal related, it can be central cause, or it can be chemotherapy associated. So the first line would be metoclopramide or haloperidol, and less likely to be effective is ondansetron, which works well in chemotherapy-induced nausea and vomiting. Next slide, please. So this child's neutrophil count recovers, but the platelets and hemoglobin are still low and he needs transfusion support. Mucositis is also resolved and nausea continues but improved. His abdomen size is now increasing, and the oncologist feels that his cancer has progressed while on chemotherapy. Many of us reach this crossroads in many patients. So is there further benefit in chemotherapy? I would kindly request if anybody wants to share their thoughts.
Anyone from the floor, like the patient is already
The
on rehab.
Yeah, the symptoms are increasing in the patient after starting palliative chemotherapy, and the oncologist feels that the child has progressed. So is there any further benefit in chemotherapy?
You can put it in the chat.
Hello,
box.
John.
Yes,
Uganda.
Sir John?
Yes, please.
Good evening, sir.
Yeah, I think we can first concentrate on management of the symptoms, because chemotherapy still will just increase the symptoms, but managing these other symptoms which are on can give comfort.
Yeah, thank you
Yes,
for
thank you.
that. So the goal of care towards comfort. And yes, we agree also with Elizabeth that the benefits of chemotherapy is not anymore at this time, and more of towards the comfort. Thank you. Also from
Yes.
Aloram, no benefit. Okay, thank you for your answers.
Before we move to the next slide, in this slide, we have mucositis. In MNJ here, for mucositis, we are also using, I'm sure Dr. Spandana also must have used, we used a paste of glycerine, sucral, and morphine, crushed morphine tablet, which really seems to be working well for the children who have severe mucositis. You have to make a paste from these three and then just apply it on the mucosa maybe 2 or 3 times a day. Next slide, please. So when we come to such crossroads, I think we should go back to our ethical principles, which involve beneficence, where we should do things that will benefit the patient only, non-maleficence, where we should not do things that harm the patient, and they look for the expected quality of life with and without treatment. And we should be just, fair, equitable, and use the health resources very appropriately. And last but not the least, the parents need to be provided with information about the risk of treatment. Next slide, please. After a week, the child's abdomen continues to increase in size. Ultrasound shows ascites and he has a mild to moderate pleural effusion. The child becomes fluid overloaded and he requires Lasix. Without Lasix, his respiratory rate increases and he's showing signs of increased work of breathing. He seems to be uncomfortable while lying down flat at night. Parents are hesitant to use morphine for this child. Can you please go back to the previous slide, Rizwana? Yeah, the parents are hesitant to use morphine to treat his breathing difficulty. So why are they so hesitant to use morphine? We have discussed in detail about the usage of morphine in the last session, but here the parents seem to be hesitant to use morphine. So anybody would like to comment, please?
Any from the floor? Have you encountered any parent in your practice regarding any hesitance in the use of morphine? May I ask Miss Elizabeth? Yes, most parents are afraid of the morphine addiction. Yeah, same here in the Philippines. How about in other countries like Uganda or in Bangladesh? Any experience?
This is John Maobole,
Yes?
Uganda.
John? Yeah, Sir John.
Yeah, in Uganda, we use morphine in smaller doses to manage. Yes, for this case, we can still continue using morphine.
Totally agree.
Yes, because it has that if it can help reduce that breathlessness.
Yeah.
Yeah,
Okay.
and the child will receive comfort, but this requires communication to the
True.
parents and also to the child, that you explain it that when we use this treatment, it will help us also in this way. But with that explanation, they will be able and willing to accept that action. But in case they have refused, it is also okay to not to disrespect their view, but also considering the ethical considerations of doing good to the clients. You have to give information to the attendants or the parents so that they make an informed decision. Thank you.
Thank you. Thank you for that, Mr. John. And yes, a common denominator is addiction. Those are the concerns of every parent that are not that encounter for the first time the morphine usage. But yes, we totally agree with you, Mr. John, that educating the parents and giving them informed decision is may shed light to the myths that they knew about morphine. So, Dr. Archana?
Yeah, Dr. Spandana, would you like to clear the doubts on being an addiction or death regarding morphine? Can you please tell them?
Yeah, thank you. I think that is one thing we are all going to struggle, because even in the country like India, India, Pakistan, and Bangladesh, I think not Bangladesh, but Afghanistan, these are some of the countries that produce a lot of opioids. But even then, we do not have access to them. We are struggling to fight for access to opioids, because one, in medical school, we are not taught about it. None of us learned about morphine. The only thing I remember reading a 3-mark question on morphine is, what are the 3 side effects of morphine? Respiratory depression, addiction, and I think constipation. I don't remember what was the other one I have written, right? So I think that is the first place where we are being not educated. And the other thing I think why we get scared is that is the only drug we keep double locked. I mean, the narcotics, the opioids are the only ones we keep double locked. We think because they are dangerous, but the reason why they are being kept there is not to protect them, keep them away from patients. It's from being misused by healthcare professionals and other people. Right? So that is why they're being kept under double lock, because they have been misused in the past. Having said that, last time we have said, if there is pain, if there are symptoms when we give morphine, the patients won't get addicted. Okay? So pain is a physiological antagonist to morphine. So we talk about agonist, antagonist. So if there is pain, the patient cannot get addicted. A lot of times we have seen, I start morphine to the child, I give 2 milligram IV, and I go, today is the first day, so I'm giving only 2 milligram IV morphine 4th hourly, and I tell the nurse, give SOS doses, PRN doses as required. And the child all night keeps telling, sister, give me the drug, give me the drug, give me that injection. And the sister next day tells me, the child is already addicted to morphine. I'm like, no, sister, the child is not addicted. When you gave the injection, the pain came down. The child is getting relief from morphine. That is why when sorry, I was just looking at the chat, very interesting points. So that is why the child is asking for morphine, not because they are addicted to it, but because it is giving relief to pain. Someone said important point, morphine sudden fall in respiratory rate. I don't think so. I haven't seen that happen in my 6-7 years of using morphine, injectable continuous infusion. Sudden stop of respiration happens with midazolam injections. I have seen that. We had to resuscitate children after after giving midazolam injections, but not morphine injection. Morphine causes respiratory depression, not arrest. Arrest is stopping suddenly. Depression is, it goes down. Suppose I take Alden here, right? And I decide to give her morphine. So Alden's respiratory rate is 14. I give her the injection. So initially nothing will happen. She'll just become sedated and she'll sleep. See, sedation, it is not a sedative drug. It is an analgesic drug, but the side effect is sedation. Right? So I never give a child morphine to sleep. Morphine is not given to sleep, right? So I give Alden injection. Her breathing will be the same, but she will sleep. Even then I do not stop. I decide I need to give Alden more morphine and I push more morphine. Then Alden's respiratory rate from 14 comes to 11, right? And it doesn't stop. She is not dying with that dose, but her respiration goes down. But even then, Spandana doesn't stop. She wants to give more morphine because Spandana is a bad doctor. She's not counting the respiration of Alden. So she pushes morphine again. Her respiratory rate comes from 11 to 8. Spandana is not at all a good doctor. So again, she's not looking at respiration of Alden. She's not checking her blood pressure. She's not looking at the sedation score. She's at 8. So I'm giving her another dose of morphine. Then she comes to 4. At least now, Spandana, wake up, count her respiration, hydrate her, think of naloxone. Spandana doesn't think. She gives more morphine. That is when Alden will go into complete hypopnea. That is when her respiration will go further down and it will not go down. Okay? So it doesn't cause respiratory arrest, doesn't cause sudden stopping of breathing. That is one thing I want you all to take home. It causes depression. Depression doesn't happen suddenly. If you are trained and if you are a good clinician, you calculate the correct body dose, you give the dose and you wait, you stand there for 10 minutes and then you count the respiration. The child is still in pain, the respiration is not decreased, the BP is normal, you can give more morphine. 10 minutes later, pain is not decreased, respiration is normal, you can give more morphine. So keep an eye on the vital signs, that is respiration, blood pressure, heart rate, and sedation, and you can give more drug. Yeah. So I think the take-home message is morphine is safe when used by trained people. And this is what we want you to take home to your countries, your hospitals, and you need to educate other healthcare workers in this.
Yeah, you start low dose and then increments, slow increments, and reassess every time, reassess your patient. Okay, so be mindful also with the peak of the action of your drugs that you are giving so that you would be able to monitor what time you have to, how many minutes, how many hours you have to reassess and monitor. So thank you, Dr. Spandana, for that information. I know that there are new doctors here and they had also some myths about morphine. That's why most of them, some of them have some reservations on its use, but proper education, proper training, guided also by their consultants, as well as they read on those medications before giving the drug is wisdom, is noteworthy. Okay, so Dr. Archana, do you have is there another slide that's following this one?
Sorry. Yes, sorry, there's some internet issue. Yeah, sorry. So yeah, this slide. Thank you, Spandana, for such clarity. So the child's abdomen continues to increase in size.
I think the slide is not moving, Dr. Ma'am Rizwana.
Am I audible? I'm so sorry. Rizwana. No, I cannot see the slide. I mean, there had been heavy rains today since evening, so I think some problem in the internet. Rizwana, I'm not able to see the slide. Yeah, thank you.
Okay.
Sorry.
Now it's
So the
moving.
ultrasound shows ascites and he has a I think we have seen this. So previous slide, Rizwana, please.
Okay. Is this fine? Archana, is this the slide you want?
I think this was the one she was reading. I think she was done with this slide.
Yes,
Yes.
I was. So
Yeah,
the next
then-
slide.
Yeah.
Okay.
Next one is this one.
Okay. I think she's not able to see it because her internet is slow. I heard
Yeah.
Hyderabad is having
No,
bad rates.
yeah. In case Spandana, yeah, in case it goes, then
Yeah, no problem.
I'll do the case. In case it stops, Spandana, I request you to kindly continue the slides
yeah.
because anyway. So the child, there was the child paracentesis was required for the child to decrease the abdominal distension, and after that his status improved for a few days. Initially, though Lasix helped the child in relieving dyspnea, now Lasix was intermittently used as it seemed to be effective. Next slide, please. Next slide, please.
Yes, I'm on the next slide, Archana. Case 1 week later. This is the one.
Yeah,
Oh.
yeah.
So over the week, a week later, the child is more sleepy and breathless, and unfortunately, the Lasix is not effective like before. Meetings with the parents to review that breathing has worsened and what this meant. So the doctor expresses that I wish that the things were different, but I worry that the child is showing us that his body is not able to respond to the treatment and he's getting sicker day by day. So the child was continued on opioids and benzodiazepines for dyspnea with increasing doses. SOS doses for morphine of morphine for dyspnea was given with significant improvement. Also, lorazepam SOS provided further relief in this child. Next slide, please.
Yes, I'm on the next slide, Archana.
Yeah, now. So over time, the child became more restless and increasing sleepiness. Dyspnea continued, was managed with subcutaneous morphine infusion. Midazolam infusion also had to be added since the child could not swallow and take the tablets orally. The abdomen was very large. Nasogastric feeds were continued at 30 ml per hour. And unfortunately, the child began having some wet noises at night, gurgling sounds, what we call the death rattle. So how to manage, and at this point of time, should feeding be continued?
Okay, so the patient is now towards the end of life. She is transitioning. So on the floor, any of the participants would care to comment on it with regards
Hello.
to the noisy.
John. Hello.
Yes, Doctor. Yes, Sir
John.
John.
Uganda. At this point, I think there's still more need for explanation to the caregivers that the child at this time, the body may not need food. Giving food may worsen the symptoms, and may cause discomfort to the child. And it is actually better to even withdraw the feeds so that there is more comfort instead of giving the food and worsen the situation. Thank you.
Okay.
John, you should be teaching this. You're doing very
You'll be
well.
part of
Very
our
good points.
Thank you, Dr. John. Yeah. So
Yes,
Miss
one
Elizabeth
more.
said already with death rattle, keep comfortable since the body is shutting down. So no more feed. So the metabolism is already slowly moving. And so feeding is not any more beneficial and may cause other symptoms or discomfort. Okay. Thank you for that, Miss Elizabeth and Mr. John.
Next slide, please, Rizwana. So now it's discussed with the parents that the nasogastric tube feeds may really not help, but on the other hand may worsen the symptoms of dyspnea, the gurgling, the vomiting, and abdominal distension. So once the doctor discussed with the family, they agreed to stop nasogastric feeds overnight, and probably from the previous day. The child would wake up and ask for some food, and the parents gave small amount of pudding and ice cream. And this child was also able to enjoy some seafood and popsicle in his last days of life. Thank you. Dr. Spandana, I would like you to take over.
I think
Thank
some excellent points by Elizabeth here regarding death rattle. Whenever we give them IV fluids and regular feeds at the end of life, we are NG tube, because the child themselves will not take. We think putting in an NG tube is very helpful by feeding the child. What happens is the water will not have any place to go and ends up in the lungs and in the pharynx and larynx, right? So they start having this gurgur sounds, and the child who was previously a little more comfortable starts getting distressed because of the feeds. So when you see that, suddenly always think, maybe I have to stop IV fluids, subcutaneous fluids, I should decrease the feeds. Don't force feed the child via NG tube when the child is dying. And as Elizabeth has said, the sound that is coming might be death rattle, and that is not a nice name to have, death rattle, but the child is usually not disturbed because of it, but it is very distressing to the family. So explaining it to the family what it is, and telling, for us it is very difficult to see those sounds coming out, but the child is comfortable. You can see that the child is not struggling. You telling as a healthcare professional that we, in the sense, the family together, we are doing the best we can to keep the child comfortable at that moment is very, very important. And I like that the child was able to enjoy popsicle and seafood. So yeah. And I can see very good comments from the chat also, like food is not beneficial at this stage. So yeah.
Yes. You know, in palliative care of children towards the end of life, the feeding should be pleasurable, not making themselves more discomfort. So we want them to have that best time of their lives, and that even up to towards the end. So comfort. So it's in the interest of time, it's already 10:31. So thank you for all the interactive session that we have today. It has been a very learning experience to all. Thank you for the practical sides of the lectures and also the case presentation. We had discussed the symptoms other than pain, like the GI symptoms, how to manage nausea, vomiting, mucositis, respiratory symptoms such as the distressing one like the dyspnea, the bleeding, we had touched it already also, and of course, feeding and giving IV fluids towards the end of life, when is it beneficial and when it is not beneficial. We were also given a skill on how to approach symptom management for our palliative care patients. Like, first, you have to have an evaluation and assessment, treat any irreversible causes. And then, of course, the non-pharmacological intervention is equally important as that of pharmacological intervention. And then different tools that we can use to assess severity, such as in nausea and dyspnea. Okay. And then, of course, we always have a good communication with the parents, especially when we are working towards the end of life care, assuring and talking with the parents at all times. And then careful attention also to hygiene and mouth care, especially when the patient is having nausea and vomiting. So it is really difficult to predict exactly or know how much time they have, but we know that they have shorter lives, and we want to have the best quality of life to them even at the end. And we also must learn recognizing the signs and symptoms of end of life. Okay, we have to recognize them, and that there are changes like the sensorium, the color, the breathing. Okay, we were able to apply the principles of the symptom management through the case presentation. And then let us hope that this wealth of knowledge that we had tonight will be translated in our practice. So if there are other questions, you can throw it in our WhatsApp chat, and any of the faculties can answer them if you have any concerns. Our communication lines are open there. But now it's already 10:34, and I hope everyone has a great evening. Thank you again, and we'll hope to see you next week for another very interesting topic and very helpful in our practice. Thank you so much for everyone. Have a good evening. Have a good day.
I just want to say, I see some specific patient-related questions. If you have anything, please post it on the chat on WhatsApp. I see regarding some child that you have, we would definitely like to help the child. So because the time is ending, we lose everything on the chat. Please post it on the WhatsApp.
WhatsApp. Yes. Okay. So thank you, everyone.
Thank you.
See you next week.
Bye. Thank you.